You got a clinical trial that Denise just presented. That's sort of the way that a trial is. And what I'm going to do is I'm going to sort of flip the script a little bit and thinking about real world implementation where it's not embedded in a trial as we sort of think about it with all of those sort of pre-planned steps, but to really look at, basically extending the sort of reach. And part of that is when you're doing these trials, the step wedge has got this maintenance phase. So you're looking at sustainability, but oftentimes you get like maybe an extra year out of that. And so from a sustainability perspective, I want you to begin to think about how you sort of move this for kind of long-term stability. And part of that is you can think about it, the implementation facilitation, unless people stay with those skills over time, it won't be sustainable. They're sort of, people are paid to sort of coach during that, but there's got to be something that lasts. And I'm going to try to give you an example from our own work where we do that. Let me see my I'm technologically challenged. Okay, there we go. And I just want to say that when you're doing this work and you're sort of working out in big teams, it really takes a village. And you can see the list, but I'll just kind of walk you through my colleagues in Ukraine to do some of this work who were researchers. And we were working with two big NGOs within the country, a couple people at Yale, both from the social sciences and from infectious diseases. And then, of course, a number of other people who were just killing it and making it happen on a regular basis. So one of the things that we ask all of the trainees to do is to, when they're presenting, is give us a problem statement, right? And the problem when we got started here was there was this whole issue that HIV incidence was still going up. It was concentrated among people who inject drugs. And they had just plateaued. Their scale up had gone up to a certain number, 8,000, and it just wasn't going anywhere. And it was really very flat. And I'll show you the data. And so they asked the question, what can we do? Because we're not getting to where we want. And they had a bucket load of money. They had a lot of global fund money. They had money to get by 2015 to get 30,000 patients. Now, I will say today, so it's 2025, we're 10 years later, they got to 30,000 just this year. So, better late than never, as they say. Oh, and then so the one thing that I will say is that if you don't bake in things that sort of change the way that the system is working, um, anything that comes up can be a threat to sustainability. Oftentimes, it's funding. This is something that we have sort of gone through repeatedly, really talking about. In this case, opioid agonist therapy is the thing that we're doing. We knew what the numbers were. What we're using as is a bundled strategy. Lynn's talked about Niatex. And for those of you who are in the training this afternoon, you're going to get a lot of the tools and the kits and the sort of the principles and how to do the coaching. And one of the implementation strategies in Niatex is like a practice facilitation, implementation facilitation. They're very similar terms. And then the thing that we're trying to measure is scale up. Do the numbers go in an increase? Now, we use the IPARIS framework, very similar to what Denise is. And what's really interesting about this is the Ukrainian context is so different than anything in the US in terms of a number of regulatory things. So you sort of have to understand all of that. And then, of course, what's interesting is the innovation is the opioid agonist therapy, which we know that works. The problem is that this is an innovation that is negatively seen by both patients and by providers. I mean, even the people who are prescribing it. And what was being asked, at least initially when we started this work, is it was the addiction treatment experts, and they were under the influence of Soviet-style narcology, and they said, "But this doesn't work. But you're making us, provide this treatment to people to prevent HIV." So they said, we're having to treat people with something that we don't think is effective. So you've got this duality where the patients are not demanding it and the clients are not really supplying it, right? So you've got a sort of a double factor. Facilitation, which is what we use, which was Niatex, and then how is this sort of perceived on the patients? And one of the quotes that we did in our formative work was, This is the treatment of last resort. So if you think about somebody who's got stage 4 cancer, only the people with stage 4 addiction were actually going into treatment, which is why they had, there was no tipping point. I mean, it just stopped right there. So we know that the evidence OAT is the only evidence-based treatment for opioid use disorder, full stop. Detox and quote unquote recovery and counseling does nothing. 8%, you get almost nothing out of that. So, and it's also cost effective. And it's very, in terms of our toolkit for HIV prevention, it's really one of the the key things that we have. And in order to stabilize your epidemic, you need at least a coverage of 20%. And if you want to reduce the epidemic among people who inject drugs, you need to get to 40%. So, we had a long ways to go. We started at 2.7%. So we had, a fair amount. So the context, we talked a little bit, what's happening at multiple different levels. I got started with opioid agonist therapy, so I had a little bit of a head start. I was invited to, with Sergei Dvorak, to introduce buprenorphine, not methadone, in 2004. So we trained a bunch of clinicians, and this was my first visit to Ukraine. So I got to get a sense of somebody who's standing up to what's going on in the region. And it was really recognizable that they were trying to do something very different, much like the Georgians, than what had been there beforehand. And you can see we introduced buprenorphine. It stopped. It didn't stop because people didn't want it. It stopped because it was too expensive. Introduced methadone, so we have a cheaper methodology. We get up, and then it flattens out again. And so we're asked to do things. And so we get into this context where we've got 360,000 people who inject drugs, and about 280,000 of them are people with opioid use disorder. And there were 7,800 people on OAT, so your coverage is really low, and there was a fair amount of money. And so we take the long arc. How do you make this happen over time? We had this volatile HIV epidemic. It was the highest HIV prevalence in all of Europe. It was concentrated. There were estimated to be 17,000 new infections per year, incredibly negative attitudes, regulations that don't look that much different than in Georgia now, and that you have to go in and get treatment every single day. Take-home dosing is not there. And when they did get treated, they got treated with pretty lousy doses of medications. They required that a panel of 3 narcologists or addiction treatment experts had to certify, and they put them into inpatient and made them detox. Let me watch you for 3 days before we give you treatment. So this is the landscape, and you had to fail that twice. And a person who's dependent on opioids, the last thing they ever want to do is experience withdrawal. So they just would drop out of that whole thing. And so that's where we were in terms of that landscape, when we were trying to say, all right, we had 7,800 people who had drank the Kool-Aid. They decided to be on it, and then it didn't go anywhere. So what we did was we then began in 2013 to understand the barriers, pretty extensive sorts of studies that got there, and we mapped it. We had qualitative interviews with 199 people who were on methadone, people who had been on methadone but dropped out. So you want to know, who are the people who drink the Kool-Aid, who are the people who drink the Kool-Aid and vomit it up, and then who are the people who never want the Kool-Aid, right? So you have to think about that from an analysis. There were a number of individual barriers about what they did like and did not like about it. They had families who said, you go on that and I'm kicking you out of the house. So there's all of that as a driver. There were also little, grandmothers who said, oh, this saved my son's life. So it worked in both directions. The organizational sorts of factors were just really insurmountable in terms of everything that had to be done in order to get on people with the treatment. It wasn't located everywhere. We finally got it up to 279 sites. And then there were all of these policy restrictions, and their Order 200 was the major driver that was restricting access to treatment. So we're implementing with Niatex this multi-bundle strategy because we're not really working at one thing at a time. You have to really target a number of things. And while it's mostly the processes that are being changed, you use the data from those processes in order to implement different areas. And we'll talk a little bit about what we did. So one of the things that we did was we looked at, what were the barriers. We used this really interesting methodology, and the biostatisticians either like this or hate it, but it's item response theory. I'm not sure if everybody can see the title up there, but and we looked at, we just said, what gets in the way? And we had a list of like 20 or 30 different sort of things, and they could check them all. And so it's a Roush model. And what really happened was is that treatment attitudes and the program. That's all right. It, I actually wrote the slides. I know what it says. You just don't. That's all. And so anyway, the bottom line. Is there a way just to make it to hide it? Hide floating camera. There you go. That was right there. No, boy, you don't want to see me. That shiny head says high floating meeting controls right there. There you go. Voila. All right. But when we began to take a look at it, what we Irma, you have to do your magic. There's something else that's going on here. But essentially, about 85% of the barriers really clustered into program logistics. Too hard to get it, too hard to get on it, and too hard to stay on it. And then the treatment attitudes were the sort of the big factors. And that was actually part of the secret sauce that we used in order to argue for some different sorts of changes. We had been sort of collecting all these barriers, and then we began to implement right as the initial invasion sort of happened in March of 2014. These are my own photos. I hopped on the plane, and there was, basically they had to shift my hotel because my hotel was on fire in the downtown area. And then these are the Molotov cocktails. I was there, and on Friday they had a ceasefire right before Yanukovych sort of left to go to Russia. And this was the day before he left. He left that night. And so this is really what was happening in downtown Kyiv. And so we're doing this all in a matter of disruption. And, the disruption was like a lowercase d rather than the later, uppercase d. And so this is the sort of the landscape with where you're doing this. And one of the things that happened that was so interesting around 2004 is Ukraine had already been saying Yanukovych was sort of pro-Russia. The Ukrainians, whenever they sort of got rid of Yanukovych, they said, we are going to do things differently. And one of the nice things about that was they said, we're going to really make sure that we take care of people with opioid use disorder. You all have had a lot of lectures around the facilitation and coaching using Niatex. I'm not going to repeat all of these, but you have to have an aim. It was really simple. Get more patients on therapy, all right? And then a number of change projects using all of the rules, people, and tools that Lynn went through. And what we ended up doing is we first started by sort of doing the change teams with really mostly community-based people. And that didn't work, to be honest with you. And it didn't work, and we don't know why, but it just didn't work. So we shifted because what everybody was telling us is we can't do anything because the bosses won't let us do it. So we shifted and we coached towards the leadership and then had them sort of do a distributed thing, which is a little different. But, if you weren't really getting where you wanted to do, you have to do something different, right? And so we would come together on a regular basis in person. We would fly over, but coaching was happening every single month, with regard to the teams. And so here we are. We're really at the annexation of Crimea. We were just been describing all the barriers and stuff like that. And we used the findings as we were starting to come up with this to really sort of channel that into the government. And the government in 2016 changed the policy in Order 200, right? So one of the things that Denise talked about a couple of days ago in terms of the way you analyze these things, this is not a cluster randomized trial or any of these sort of step wedge designs. This is where we're looking at interrupted time series, one of the less strong. But for what you're doing, since we don't have a comparison group, it is something where you can begin to see with if we coach to anything that changes, we're going to be able to take a look at a difference. And so one of the things that we did was we started Niatex, we made some changes, Order 200, and we'd created a collaborative of people who were now advocating for change. And so the government changed the orders with that. We tailored the Niatex to a different group of folks. And then we did a number of different sorts of things. We had basically learning visits. So one of the strategies, learning visits that was embedded within Niatex, That was something that was, I think, new for Niatex. And then we had these collaboratives. We started introducing stimulus lectures because that's how you learn from outside the organization. So that's one of the things. But it was really in a setting where the ideas around what methadone was or was not, even among the people who were delivering it, was sort of off. And so we have a number of these things that are going on here. The V's are standing for visits. And then we created challenges. So an incentive-based system and said, all right, do you need to do something else? If you can actually increase the number of patients by 20% at your site, can you actually end up with a different outcome? And I'm going to take you up through some of this processes. What was really sort of very good about this particular strategy is, remember, the aim is scale up. There's only two ways to get there. You bring in new patients and you keep the ones who are on treatment. It's a chronic relapsing disease. People should not be coming off of treatment for the most part. A small percentage will. And really, one of the things that was sort of part of this model is that if you increase the number of patients who are getting onto treatment, the clinicians themselves are getting better experience. And when they get better experience, that improves the quality of the services that are delivered. And then there's a downstream effect, because if the community sees that people are getting quality treatment, word of mouth means they bring more people in, right? People are not going to come in to a place that's not giving good services. Think if you're a restaurant and you're serving hachapuri and the hachapuri has got really lousy cheese on it, nobody's going to come, right? So you have to fix the cheese or whatever it is. That's exactly what was part of the model that was built into this. And one of the things that we did really early on was we looked at the data and we said, what is it that's really part of the cascade that's the dropout? And people were coming onto the program, but they were not, the same number of people were dropping off. So how do you sort of change that dynamic, that bathtub that's got water pouring in and a big hole in the drain? So we looked at it and we took a look at one of the really important things that we could change, that we could coach toward. And that was dosing of the methadone. And we really established some pretty good data that sort of guides what's happening really sort of globally. And one of the things that you can see, and these are some of the highest retention levels of being on methadone of anywhere in the world. But you can see that if you were on a dose of greater than 85 milligrams, 90 milligrams or more, at the end of 3 years, you've got 80% of people on treatment. This is better than in the US, to be honest with you. We don't have numbers quite this good. And maybe part of it was the directly observed therapy. So what's important is that when you get to, let's say, 90 milligrams or more, you get the highest level of retention. If you go from anywhere from 40 to 85, you really have a huge drop-off. You've got a 20% drop-off in treatment over the course of 3 years. And then you drop off another 25% if you're on 40 milligrams or less, which is what we call a non-therapeutic dose. They're all non-therapeutic doses until you get up to this. And one of the things that's important is we tracked it over time. I'm not going to present it here, but if you even look at the first 1 month, getting them to an adequate dose in the first 1 month is the single best predictor of them actually staying on medication. So it's doing it early. So you got to think about this. And at this time, they were giving them 25, 35 milligrams and going up by 5 milligrams a week. That's not a practice. It happens all through this part of the world, but it's not a practice that's going to keep your patients. So let's take a look at it. We talked about an interrupted time series. This is the slope. We're increasing by a couple of patients per month. It's really relatively slow, or quarter, if you will. And then all of a sudden, and we're coaching to whatever the context is, right? So you're going up, but you're going up slowly. But we want to go more. We want to close that implementation gap in terms of what we want to get onto treatment, the 2.7% that's there versus getting to even 20%. And that's a magnificent number to get to, but we didn't get there. Order 200 changes, and it says you can do things that are different. And the minute that you know you can do something different, you implement towards it. So the coaching said, all right, we know what makes people drop off of treatment. They don't get on an adequate dose. And we said, what does it take to get your patients up to 90 milligrams or more? Very, very simple sort of coaching. The other thing that happened with the change of order 200 is it says, if your patients are clinically stable with a negative urine test, over the course of 6 months, you can give them up to 10 days of take-home dosing. Two factors that we believe that were majorly critical. But also, if you did that, Other patients would say, that isn't so bad if I can only come in 3 times a month, right? So more people would come. So it's got this self-perpetuating thing. So we coached to those sorts of things. They were really simple things, like, oh, well, don't get a full panel and they've got a positive cannabis. And so I'm going to not give them medication. If you don't test for things that you're not treating, don't do that. It's more expensive and it's stupid. Yeah, but I want to know. I said, what are you going to do with it? Tell them to quit smoking a joint? It lasts for 42 days. Why are you wasting your time? And so, we, now what's really interesting is there's heterogeneity. This was like the group of people who were doing that. And, one person said, yeah, that's a great idea. Why do I want to do that? Other people said, no, 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 I have to know. I have to know. Do what? Do what? So we coached to that sort of thing, getting up onto sort of dosing. And once we did that, what you see is the slope of the rate of increase actually goes up quite dramatically. So from an interrupted time series, slope A versus slope B is beginning to get a change. Now, what's interesting is you're baking in a sustainability plan because you're focusing on things that matter. A lot of people do things in clinical practice that don't matter. What matters here is the dose and getting people, to take home dosing. And so we're going on our merry way and we're doing better. Now, this was a sort of the first change was based upon a planned change. We used the data, we got the change. So for policy changes, interrupted time series are actually quite good methodological strategies to use in implementation science. Well, guess what? We had a big change because when COVID-19 happened, the regulations changed. The Ministry of Health said, please put as many people on take-home dosing as you possibly can because we don't want people through our streets. We've got lockdowns. And if you can put them on take-home dosing, we're going to have our staff who are less exposed, and we're going to have our patients who are less exposed, and we can maybe, from a containment perspective, reduce the risk of COVID and related death. And that's really what they wanted to do. Now, what happened from a coaching perspective is the doctors, many of them, said, how do I do that? If I give them take-home dosing too early and not wait 6 months, they're going to overdose and die. And that's a legitimate concern. What you don't know, you don't know. And so we had to coach towards that. So what happens? Well, if you move somebody to take-home dosing, why don't you call them every day? Or why don't you call them every 3 days or something different? Because you're concerned. You want to make sure they're okay, right? You're not going to observe them. Now, later on, after all this was over and essentially nobody died, from this, they started introducing the video observed therapy, which was, the barn's already out of, the horse is already out of the barn by that time. But nonetheless, we coached to that. And then we said, all right, if you feel really uncomfortable because they are, you're afraid that they're going to overdose, get them up to a good dose quicker. So we did early dose escalation. Instead of like going from 25 with 5 milligrams once a week, we went up 10 milligrams every other day or every 2 or 3 days. And so we changed what we did. Was there a lot of anxiety by the clinicians? There was, but because we were on calls and every quarter we came together with the whole group and somebody would say, yeah, I just induced 30 patients using a rapid dose escalation and everybody did well. And somebody goes, aha, we learned that. And so people began to sort of learn from each other as part of the collaborative learning process. The other thing that we did was we were struggling. And so what's the expression? If you're not getting the result that you want, you have to do something different. We offered a challenge and it was not much money. It was $500 or so. Went a long ways in Ukraine and the chief narcologist could distribute it however they want. And essentially what we did was we did a 20% scale up challenge. And everybody who is in red and green met that challenge. Once again, you've got heterogeneity. You're not going to get every clinic to do the same thing at the same time or the same speed. If you've looked at what Luke Davis presented, Rogers' diffusion of innovation, you've got the innovators, the ones who are going to do everything real quick. You've got the early adopters, which is probably what these people represent, and then you've got you've got eventually the laggards. I hate that term, but the delayed adopters, if you will, the never adopters. And those people are always going to be there. And we had a couple sites where they just didn't do squat. And that's okay because overall we were going in the right direction. But what happened to this person with a 71% increase? What do we call that person? That's our champion. And we called him a champion. Pardon me? We're not to the internally displaced. I'm going to get to that. Don't you worry. We're not even at the war. We're at the COVID war. We're at the infectious disease doctor war. We're going to get to the military war in a bit. So anyway, what happened was is that we, and Order 200 was changed. We told you what we switched to. COVID-19 really did some really accelerated things. So these are what we call disruptions. Disruptions are the things that makes us anxious and not sleep at night. But we can actually change what we do in terms of the coaching to all of these sorts of things. And I'm going to walk you through some of this. Now, what we did was, as we're going through this process and we see the change in order number 200, and we began to actually coach differently and provide stimulus lectures and things like that, we wanted to try to see what is it that we can pull out of the NIATEX coaching in this particular context. So we've got these international visits. We looked at collaboration. We looked at what we call risk takers. These independent implementers was the term that we used. And then we have all of these other sorts of things that are sort of baked into the whole process. And what we did was we did something that's called a factor analysis or a latent class analysis. And we really found that the groups of physicians, remember we talked about heterogeneity, that they were actually really quite diverse. And so we've got a group, and interestingly enough, it fell out almost equally, but we have these engaged collaborators. And these were people who had really pretty good leadership skills. They were pretty high on the leadership scale. Their collaboration climate was the highest. That is, they wanted to learn from each other. So they were listening. They weren't just doing my own thing and saying, I'm the cowboy with the gun. They were basically saying, I'm an army and I'm a general, right? So they were working together. We looked at the independent risk takers. These are the people that we know that are the ones who are trying anything new. They're looking for every shiny object, but they throw things out. They don't hold on to the coins, if you will. They were lower, but not the most. And then we had, whether they did a learning visit to the U.S. The independent operators were the ones who were really high on the independent risk takers, but they didn't learn from each other and they didn't sustain things. So it's a sustainability issue. And then, of course, the delayed adopters in Rogers' diffusion of innovation, the laggards, the ones who just didn't do anything, and so we have these sort of characteristics where they fell into this. And when we did this sort of thing, we then sort of said, all right, what's happening from the point of changing the order? We're coaching to them all the same way, but what happens when you do that? And remember, there's two things that we're going to look at. We're going to look at total scale up, which we know that went up, but we're going to look and see whether they added new patients at a certain rate and whether they decreased dropout. One of the things I want to say is these independent operators in real world settings, you recognize them. They're people who are always trying new things, and you think of them as sort of really interesting, but they're different than the ones who are the engaged collaborators who learn and teach for each other. They were willing to do anything new, so they were our people who were the first ones to do the buprenorphine take-home prescriptions. They did the take-home dosing early. They knew it all. They would come into the meeting, and you could recognize them. I mean, as it turns out, I'm not going to tell you who any of them were, but we sort of had a sense of who they were, as we were going into the meetings. And they're not really seeking support or ideas from their peers. And so what they did end up doing when we sort of looked at this was we looked at we mapped on what's happening with these three different groups. And what you can see is the engaged collaborators enrolled new patients at a faster rate. The independent operators who were in the blue were just underneath of them. And the delayed adopters, if you will, are the ones, they still increase patients, but not as much. So once again, who's closing the gap the fastest, sorry. Then, of course, we look at the other part of our little cylinder. We've got, this is the new patients who are coming into treatment. But what's the rate of dropout? Well, as it turns out, our independent operators, the ones who don't work in a collaborative type of setting, they had the highest rate of dropout. So they did pretty well getting new patients in, come, but I'm not going to pay attention to you once you get there. And so they didn't do quite as well, but you have the engaged collaborators who not only worked at opening up the front door, but closing the back door in order to keep people, onto treatment. We learned something else that was interesting with this because we really thought we should think about what's happening to opening the door, that is getting them to touch the system, right? And what you can see here is we did a sample of about 560 people with HIV on methadone. We did a big, huge survey of 2,000 people who inject drugs. And we stratified them into three groups. And that is the first group were people who were on methadone. The next group was people who had previously been methadone, so they dropped out. And then we have the group who had never seen methadone. And what's interesting is because they were screening people, that some of the change projects were screen everybody who comes in through the door for HIV, you jumpstart the cascade and it has a sustained effect. So when Dato was talking about what happens for the people, basically stopping to smoke, well, that's one thing to say stopping to smoke, which is further down the cascade, but you got to do the things at the beginning, right up front. And so it was a learning lesson that just opening up the door and getting people to come into treatment can jumpstart screening, evaluation, treatment, and retention on the strategy that is better than having them never touch the system at all. Let's move to the COVID pandemic. So we were scaling up at different rates depending upon who you were within that particular setting. And so we've got COVID-19, which all of a sudden we see a significantly faster rate of scale up. And so the question is what happened? So when the government ended up changing the regulations and saying, get everybody on take-home dosing, we started actually doing coaching towards safe transition to take home, get them up to a dose faster, and then once they stop using drugs, move them as quickly as you can. Instead of waiting 6 months or 3 months, probably should not be a time interval. It should actually be, do they demonstrate clinical benefit? And we coach towards that. Hello. And then we did telecommunication where they actually talked to folks to make sure that they were still doing okay. And then we actually did dosing escalations and adequate dosing. So we were coaching to getting your patients up to 90 milligrams, and then within the first month up to 60 milligrams. So what happens? So they have the opportunity. They go from having 53% of people on take-home dosing. They had done a really good job between 2016 when they changed the policy to getting at least half the patients on a treatment. But what they did was they moved another 30% to take-home dosing. What does that mean? That means I spend less time seeing patients. Patients spend less time there and actually taking care of their families and doing the other sorts of things that they want. And what was interesting about that is it translated to actually about 86,000 hours of decreased work dispensing methadone. That's even if you say it only takes 5 minutes. The paperwork was actually probably longer. We were being conservative. And so we said, okay, did we have a benefit? Well, we have 86,000 hours of free work. Maybe you just want to go home and sleep, or maybe you can sort of do other things to engage your patients like telemedicine. And that translated also to 1.2 million fewer visits. Now, let's think about that. When you have a demand, that keeps people from staying on treatment, all right? There's a demand on clinicians. If I have to have 1.2 million visits, I don't have time to take new patients. If I have patients who have to come that many more times physically across town or whatever amount of time, what gets in the way? They can't go to the job. They can't watch their kids. They can't do these other sorts of things. So demands are really important. So what that did was that freed them up. But then we had to pay attention. What else do you worry about when you give people take-home dosing? What did our clinicians tell us? Yeah, overdose. So we have to look at mortality. Well, guess what? Mortality was no change. Actually went down, not statistically. So did we kill them? No, we didn't kill them. So we did no harm, and we only had benefit. Now, let's see what happens with real patients. So what we did was we basically compared the year of COVID, 12 months forward, and we looked at the exact same time period 1 year before, all right? And what you can see is that the proportion who were getting take-home dosing, remember they were told to move earlier. When you look across this area right here, you have essentially about a fourfold, 3 or 4-fold increase in terms of getting take-home dosing just in the first quarter of each year. It's is sustained. And then by the time you get to a year, because the old way, they were waiting at least 6 months to get them onto treatment. you actually have some parity that no longer is significant here. But once again, you're jump starting patients to stability early on. And what does that translate to? Well, it translated overall between these two different years in terms of retention benefit. Patients were significantly more likely to be retained on their methadone treatment. But the other thing that it did was it actually changed the rate of in new admissions across the country. And went from 236 across the entire country to 284. So they had more time to enroll new patients because they had less time spent doing other things, and their patients stayed in care. If you just stratify for those who got take home dosing versus those who were not between the two time periods, once again, you see a 30%. So the biggest contributor to basically keeping your patients onto treatment is actually giving them some autonomy. We have believed for a million years that our patients are not reliable. Guess what? The data speak for themselves, because if they weren't reliable, they'd be killing themselves. All right. So these were important. And we probably could never have done this without COVID, because the people who were legislating were saying, you need to send those patients home because we don't want our staff to get sick. Maybe they cared about the patients too, but they didn't want their staff to get sick. And that created what we call an opportunity. But we had to coach to it. They were scared. So coaching is really an important part of this. What they did was the other factors that sort of contributed to retention was higher doses of over 90 milligrams being HIV negative or being new to antiretroviral therapy. And we've looked at the data repeatedly in a number of different ways, and there was no survival loss. It was not statistically significant. Now we get to the war because we have yet another disruption. And what you can see here from a sustainability issue is that what you learned before adds on to things because they learned all these skills. And because they were as part of a learning process, we're not doing this anymore, and they've continued to scale up. So we think of this as a win. You know, I hate to leave and not be able to go there and hang out with my friends there. But on the other hand, I feel like there's a legacy that's left here. So we sort of basically, we freaked out. I knew a week, the ambassador had told me a week before that this invasion was going to happen. We started working with them even before the invasion. Of course, they said, everything's fine in Kyiv. It looks good. It was not fine. We knew. The ambassador had already said that there was a problem. And so we described some of those things, and we sort of wanted to think about where were things with regard to coverage. And once again, remember, we talked about the heterogeneity. We've got basically, we had already scaled up more than double from where we had started. In the coverage rates, we have, you know, essentially 4 or 5 places that were already over the 10% coverage here, and we had a number of them that were in the 6 to 10%. And these are all the ones who were still under, you know, the median of where we were. So we see some places that are being a little bit more innovative than others, and that's not surprising. So when you go to collaborative learning, you can learn from those folks. And what ended up happening was take-home dosing went even faster because they said, get those people and give them some freedom because we don't want them to get killed in a bomb or a siren. It was really very sort of scary work with the invasion. And there was actually, because people, you know, they relocated. There was a lot of displacement. There was a loss of about 800 patients from methadone that happened in the first 3 months, you know, after the invasion. So that was legitimate. And that was, you know, we were really anxious and we were coaching, and they actually allowed patients in the conflict regions to have up to 30 days of take-home dosing. And of course, the doctors were scared to death, and they did all the usual things that they had done before. But what you can see is that they actually hopped back up on the horse and they continued to do things. And we changed our coaching to weekly. We had much, much more frequent coaching with them. And then, of course, we have the scale up. These are the patients who are only in the governmental programs. There's another 10,000 people in the private program. So they've got coverage rates up to about 30%. But this really required sort of regular, I mean, weekly Zoom meetings with, you know, sort of a large number of people to sort of go through what to respond to. There were a number of these sorts of responses that happened. There were all of these concerns. And I would say that these are the things that would come up in the coaching meetings that we would actually sort of work with them. Stabilize the message was the same: stabilize the patients, do things that make it more flexible for them, and keep in touch with them. And so those were one of the problems. The other problem that happened was the program said, oh, holy cow, all the private clinics their access to medications in the pharmacy disappeared. So they couldn't get medication. So they were all flooding at least some of the other sites, and there was internally displacement. So we wanted to take a look at what was happening. There were some supply chain changes, and then there were a number of issues with regard to enrolling new patients because one, their drug supply was no longer coming in. They feared withdrawal and they wanted treatment. And we had some places that said, we don't know what's happening with our methadone, we'll do nothing. And other places who said, we'll worry about that later on down the road, let's stabilize and take care of our patients. And that was a discussion that happened as part of that. We did a fair amount of work trying to describe what's happening. You have this sort of westward sort of move. You have your conflict region with annexation that's happened over in the Donbas region. And you have what we call nearby displacement. So you're right from the conflict to a neighboring city. So Poltava was one of the central sites, Kryvyi and a few of these other sorts of sites. And then the others who said, I'm getting the heck out of Dodge. And we have this whole movement. So we've been sort of monitoring what happens with regard to that. And you can see that there's a fair amount of the largest dropout is happening in these regions. They just stopped the medication. These people were flowing over here. And so you can see that large amounts of the whole population in terms of who was on methadone with a shift that was moving to the side. What we see is that when you sort of look at these various different kinds of regions, whether they're in the front line, whether they're in the targeted region that's nearby, whether in the remote region in Lviv over in the far west, you can see that people who got internally displaced, they were significantly more likely to drop off from treatment. And what was factors that really resulted in them staying on was whether they were on buprenorphine, whether their dose was optimal. If they were up on an optimal dose of 90 milligrams or more, they said this is important, right? And they were less likely to drop out, and a couple of other factors. Take-home dosing was another key factor. They could travel, they could flee and get to another place where if they were not on take-home dosing, they went into immediate withdrawal. So those were really important factors. There were some really interesting things that happened, what I call situations where private clinics and government clinics actually collaborated. Was really very striking. I mean, part of it was just by fiat. There was a lot of controversy about us writing about that, but it was real. And, you know, in strange times, people have to do something different, which is what they did in order to really sort of protect their methadone supply and make sure that people felt like they had a safe place. I will say that the other thing that is really key is just the Ukrainian people themselves. These are three social workers. I was asked to present this at the United Nations soon after the war on Women's Day in May of 2022. So we're just a couple months in. And they wanted to send a message for me to sort of present to the UN. And, you know, I don't speak Russian, but the woman in the bottom, she has a sign that says OAT equals life. And I think that's translated to SMT, but I wrote OAT. And then, of course, people remembered what happened in Crimea when 800 people were dropped off of treatment the day that annexation happened, and 10% of them died within 6 months. She said, we remember Crimea, Lugansk, and Donetsk. And then the last social worker was Continue Life without interruptions. These were all women who were social workers, but also who were on treatment. So I will close this down with Slava Ukraini, and I'll take any questions if we have any time.
Thank you so much, Frederick. We have questions from Maka.
Time preparation. Okay. Excellent presentation and study. Um, Congratulations. I would take some of these slides, I mean, care cascade after the intervention, and take home those results and show our Minister of Health, who has some doubts in OAT program and considers in a short term to close them down. This is a strong advocacy tool for us, and please share, Irma. My question is, what was the selection criteria for patients to be appropriate for take home dosages? How did you select for your study?
Well, how I select or how other places select? So, you know, when you think about addiction treatment, what you're really doing is you're inducing a patient onto treatment. That's what I call the dose escalation, right? And then you're stabilizing them, and then you're maintaining them. And, you know, from a clinical perspective for me, I really want to, one, get them from the induction to the stabilization period as quickly as possible. So if you have a place that gives 5 milligram dose increases per week, it's going to take forever. And I got news for you. If you're a person who is dependent on opioids and you're not getting an adequate dose, the brain doesn't feel good. So you say, what am I taking? I'm taking this really awful medicine that's not really helping me as much as I'm not shooting up anymore, but I'm not feeling good. So I would say that I would basically say anybody who can get to stabilization is probably somebody you can consider. And this wartime thing where we had 92 or 93% of people who were, you know, got moved and they did well is probably what I would do. So I don't like to put a time on it. Everybody wants to. I mean, Ukraine now is back at 3 months. It's better than 6 months. So they changed their policy. Um, but I don't know that that's really set in stone. By the way, we did the same study with take-home dosing in Kyrgyzstan, found the identical, superimposable results. And it's really all about the dose and the take-home dosing. Now they only give 5 days, but you know, and it's a big bottle. I mean, there's some difference with it. So the benefit was not quite as much, but no increase in mortality. So if I were having to say things, I would say treat to stabilization. We do buprenorphine. My patients are stabilized in 2 to 3 days because I use 24 milligrams and I get them up to a whopping dose, and they're doing well. And we never ever make them come in for directly observed therapy ever with buprenorphine. I give them a prescription. In fact, I call it into the pharmacy. They go pick it up. I tell them how to do the induction. They all know how to do it. I mean, you don't have to teach anybody. They're smarter than we are. And you let them do a home induction and call you if there's a problem, or you check in with them. I mean, when I first started this, I was always like, checking, are you okay? Are you okay? I feel a little bit bad. Now I just have a cocktail and I just give it to them. And so is there a magical time? No. Stabilization. It's going to be a little bit more challenging, I think, when they have polysubstance use and other sorts of things. But you can modify and change it a little bit.
And second question regarding long-acting buprenorphine they have in Ukraine. They started last year, as I know,
Yep.
or this year. If you are aware, do these patients who were involved in your study also were included in that study as a continuation? Is the same?
That happened later on. At the end of that, they're in the database, so they're there. The problem is that when people make a decision around long-acting injectable, they don't do it for the right reason. They will take patients on methadone who are already doing well because they want to get them onto this new treatment. The doctors are like, it's this innovation, it's this new thing. You know, we publish data from the US and we have the fentanyl problem, so it's a little bit different. The patients don't stay on the injectables. They just don't stay on it very long. They stay on it for like 3 months. And in 73% of them, we have to supplement it with something over the top. So not only are you giving them this medication that's supposed to free them, but they're still taking medication on top of it because the dose is low. It's not the 24 milligrams that we need in the US. I don't know that you need 24 milligrams here because you don't have fentanyl, but we have very potent opioids over there, so we have to think a little bit differently. And, I'm thinking about long-acting buprenorphine for the patients who are really in a bad situation where they can't get to the program every day. I mean, if you live 100 kilometers away, that's who I want to start. Come in, let me just give you the shot and go away. But if you're living next door and you just want to practice with your new medicine, that's not the right patient to do it. It gives them some freedom. It's not going to be the most perfect medication. It's still trying to find a home. I think that there are patients. I think there's some benefit for people who are transitioning from incarceration. Those patients really probably are pretty good candidates. But I can tell you that once you get them out there, they're not going to want to stay on that forever. So you need a plan to move them back to the sublingual. And then there'll be a few patients who just say that the medication just tastes awful. I don't like it. And you'll find it. This is where a decision aid would be a really good idea for people to make, changes. An injection of buprenorphine for a month is $1,200. Buprenorphine sublingual is it's about $8 to $10 a month with a generic. Yep. Other questions, comments? Tomatoes? Hachapuri? This one? These are all published, yeah. If you type my name, Lynn's, and one of the people who did a lot of the analyses is Roman Ivasi, he's Ukrainian, you'll find a lot of the papers. Yep.
I have one question. It's very interesting. My question is, you have said that.
No, you're good. I mean,
I'll stand here. You said that you started with an lower level study learning groups and it didn't work and you had to move higher because they were saying that bosses does not allow us to do what we want. So you started on the implementation level, then you got higher, but the main breakthrough happened when this order 200 were changed, right? So it was going up, not, and did you notice this in other post-Soviet countries as well? Is this how this thing operates in certain countries where you have to like really start to change some regulations or some orders to achieve the breakthrough?
Yeah, so I would say that it was a convergence of many things that were going on. So there's never like that's why we did the latent class analyses to find out what were some of the sort of factors that were going on there. What was interesting is to think about this is the policy changed so that people could potentially do something different. And then we coached to the policy change. So there's two things happening. One, there's just the change. And if you were just to monitor that with no implementation, that's letting it happen, right? What we did was we not only let it happen, but made it happen. So there's a couple of other things that are probably part of that, that sort of sauce that really very steep differences. I mean, the statistical change is huge in each of those. It was even more so, during COVID. But policies also can go in the reverse. I mean, you all have got a policy change around methadone here, which I think is going to take your patients down. You can study that. That is something that is studyable. And if you've got access to the data, we can tell you how to study it or we can do it with you. So. Other questions or comments? What's next?
You are perfectly